Thank you to the selection committee for the opportunity to share our research. Dr. Eric Paulai has the following disclosures. The other authors have no disclosures. Bariatric surgery is an effective treatment option for clinically severe obesity, shown to result in greater weight loss and resolution of obesity-related comorbidities compared to non-surgical options. Obesity is a well-established risk factor for the development of ventral hernias. In patients with both clinically severe obesity and ventral hernias, debate continues regarding the optimal management strategy. Two management algorithms have been commonly proposed: concurrent bariatric surgery and ventral hernia repair, or staged repair with bariatric surgery preceding ventral hernia repair. A prospectively maintained database of patients enrolled in the institutional surgical weight loss program was queried to identify patients undergoing bariatric surgical intervention. The electronic medical record was then used to identify all patients from this cohort with complex abdominal wall hernias undergoing laparoscopic sleeve gastrectomy following referral from an abdominal wall reconstructive surgeon between February 2014 and February 2020. Consistent with existing definitions in the literature, patients were classified as having a complex abdominal wall hernia if, on hernia consultation, the abdominal wall reconstructive surgeon determined that a component separation would be necessary to achieve fascial closure. Patients undergoing revisional bariatric surgery and those without at least 30 days of follow-up were excluded. Our hernia-centered policy is to refer all patients with clinically severe obesity for evaluation with our institutional surgical weight loss program. Our definition of clinically severe obesity mirrors commonly accepted qualifications for bariatric surgery of either body mass index greater than or equal to 40 or BMI greater or equal to 35 with at least one obesity-related comorbidity. In patients with complex abdominal wall hernias, abdominal imaging is reviewed in a multidisciplinary manner with both the bariatric and abdominal wall reconstructive surgeons to determine feasibility of laparoscopic sleeve gastrectomy and subsequent ventral hernia repair. To be considered for ventral hernia repair following laparoscopic sleeve gastrectomy, all patients had to sustain sufficient weight loss to bring BMI less than or equal to 40. Axial and sagittal computed tomography imaging for one of the patients in the series demonstrates changes in visceral adiposity. Panels A and B are from prior to laparoscopic sleeve gastrectomy, and panels C and D show following the sleeve gastrectomy. The dashed lines indicate the hernia defect. Panels A and B again demonstrate the abdominal wall appearance prior to sleeve gastrectomy. Panels C and D demonstrate abdominal wall appearance on the day of ventral hernia repair. A total of 20 patients were included in this case series after meeting inclusion criteria. There were equal numbers of males and females in the series, and average age was 54.3 years. Most patients, 80%, were American Society of Anesthesiologists Class 3. Mean BMI at initial hernia consultation was 54.3 kilograms per meter squared. Mean hernia width was 16.9 centimeters, and mean length was 22.0 centimeters, resulting in an average hernia area of 394.9 square centimeters. 90% of patients had hernias that involved the subxiphoid or epigastric regions. Most, 90%, of the hernias were incisional, of which 61.1% were recurrent, with a mean of 2.5 plus or minus 3 prior repairs. Patients underwent laparoscopic sleeve gastrectomy on average 10.5 months following referral from the abdominal wall reconstructive surgeon. Average operative time was 121.2 minutes, with a subsequent average length of stay of 1.6 days. All patients, except for one, required adjustment of laparoscopic port placement to allow for peritoneal access outside the complex abdominal wall hernia, with port placements through the hernia defect after initial port placement and lysis of adhesions. Only 4 patients did not require lysis of adhesions. No patients underwent temporary hernia closure at the time of laparoscopic sleeve gastrectomy. No postoperative strictures, leaks, or new onset gastroesophageal reflux disease were observed. One patient experienced postoperative bleeding necessitating reoperation. Otherwise, no other 30-day complications, readmissions, or reoperations were observed. 16 patients underwent subsequent ventral hernia repair, on average 13.5 months following laparoscopic sleeve gastrectomy and 22.6 months following referral. No patients in this series were lost to follow-up. Mean BMI at ventral hernia repair was 34.9 kilograms per meter squared, for an average decrease of 22.2% of preoperative BMI, representing a statistically significant difference with a p-value of less than 0.0001. 2 patients had a hernia-related complication, both bowel obstructions with one requiring surgery, between the period of initial hernia consultation and ultimate repair. Hernia recurrence was assessed clinically and/or radiographically on average 20.9 months following ventral hernia repair, with no recurrences observed. Mean BMI at last follow-up was 37.5 kilograms per meter squared, for an average decrease of 20.7% of preoperative BMI, again representing a statistically significant difference with a corresponding p-value of less than 0.0001, with a mean follow-up period of 17.2 months subsequent to laparoscopic sleeve gastrectomy. 7 patients experienced some weight regain following ventral hernia repair, with 1 patient having a higher BMI at follow-up than on initial hernia consultation. Of the 4 remaining patients who had not undergone subsequent ventral hernia repair, 1 is currently scheduled for an elective ventral hernia repair, while the remaining 3 continue weight loss efforts as their current BMI is prohibitive of an elective ventral hernia repair. Laparoscopic sleeve gastrectomy can be performed successfully even in patients with complex abdominal wall hernias. Outcomes do not appear to differ significantly from typical patients undergoing laparoscopic sleeve gastrectomy. Further study with larger cohorts is warranted to better delineate complication rates in this population, as well as to determine long-term outcomes. Thank you.